Yes, yes, doctor.
Sorry. So thank you, Dr. Chitra, and thanks to ARC for the invitation. So I'll basically start with just defining refractory glaucoma, which is defined as uncontrolled IOP with evidence of nerve or visual field deterioration, despite maximally tolerated topical and or systemic AGMs, failed surgical treatment, or a combination of surgery and medicines, or a high risk of failure of trabeculectomy. Some of these have already been covered in the today, so I won't go into great detail. And these are the common refractory glaucomas that we come across. It's important to remember that when we treat these eyes, we have to think about visual prognosis. We have to look at the other associated conditions and consider the conjunctival status before we decide what to do. And these decisions are even more important when you look at one-eyed patients. If you have an eye with good visual prognosis, then aggressive management is the key, and we tend to avoid cyclodestructive procedures if you can. If you have an eye with a poor visual prognosis, then less aggressive management is what is, then you can consider more aggressive management like cyclodestructive procedures. And the aims there are to basically keep the patient pain-free and preserve cosmesis. If the patient is one-eyed, you would again try to avoid cyclodestructive procedures and try to preserve vision as best as you could. The options are medical, surgical, and the others. And I'm going to talk to you mostly about the others today. But when you look at medical management, there is a role for medical management in some situations. If you have somebody, let's say, with a chronic uveitic eye like this, where you get recurrent steroid responses, and the IOP can be pretty high, it's a fairly badly scarred eye, fairly inflamed eye, you can try and cover an acute IOP spike with systemic carbonic anhydrase inhibitors if you're trying to see a downward trend of the steroid response. And if the disc is relatively healthy, you can probably wait a little while to do that. But if the situation is something like a hyphema or somebody with a recent corneal graft, where the risk of a graft failure or a corneal blood staining is high, you don't wait that long and you intervene earlier rather than later. So when you look at surgical options, is a repeat trabeculectomy an option? It is an option if the conjunctiva is mobile. And also in an eye like this, which has had a previous trabeculectomy, where the previous trab has worked for 3 to 5 years, and there is space to do a second trab, you would consider doing a second trab, provided your gonioscopy shows you that there is no high PAS in the superior angle, which would impact your surgical success. If the conjunctiva is not mobile, as in this eye, then you could consider putting in a glaucoma drainage device superiorly. If the entire superior conjunctiva is scarred, you could even try putting the glaucoma drainage device inferiorly. So these are all options that you would consider if there is if you're trying to preserve vision to the best of our ability in these patients. But if you have something like this, which is an eye which has had multiple procedures, you can even see a glued IOL over there, a buccal, inflamed, stuck conjunctiva, you may have no options but to think in terms of cyclodestructive procedures. And cyclodestructive procedures aim to target the ciliary epithelium and reduce aqueous production. And typically we use cyclocryo or conventional diode laser photocoagulation. Both of these have the highest risk of phthisis, which depending on the studies that you look at would be anywhere between 1 to 3%. We also have the micropulse laser available to us, and we also have endoscopic cyclophotocoagulation as an option, in addition to the options, other options like a high intensity focused ultrasound. So when you compare the 3 diode procedures that are available to us, all of them use the similar laser, even though they have different consoles. The energy that you use is the highest for a conventional diode cyclophotocoagulation, which is about 1500 to 3000 milliwatts. The endoscopic laser uses the least, and the micropulse uses something in between. The duration also differs because it is per spot for the conventional laser, and with the micropulse, you give it for about 100 to 200 seconds, depending on whether you're treating half or the 360 degrees. The extent of treatment for both the conventional and micropulse is anywhere between 6 to 12 clock hours. In the endoscopic laser, you tend to be a little more conservative. You do only about 3 to 6 clock hours at most. And the area of the eye that you're treating is the pars plane eye for both conventional and the endoscopic. For the micropulse, you're actually treating the pars plica, and that's why the probe is a little larger and is placed a little further behind the limbus. So in a traditional diode cyclophotocoagulation, you would use a G probe like that, which is placed at the limbus. And when you hear a pop sound after delivering the energy, you tend to reduce it a little bit because a pop sound is an indication of ciliary body destruction, which is not what you're trying to achieve there. And if you look at this UVM picture, you can see that the ciliary processes have become atrophic on the right, in the picture on the right, post diode CPC. And this is what can happen very often, and this is the reason why you're worried about phthisis in these eyes. This recent paper by Harry Quigley, where they looked at 236 refractory glaucoma eyes that underwent a diode cyclophotocoagulation, showed a 70% success rate at final follow-up. But here, don't forget that success was an IOP reduction of 20% and an IOP of less than or equal to 21 millimeters of mercury. So this is a fairly reasonable success rate for refractory glaucoma with a single procedure. If you look at the endoscopic device, this is what one of the devices looks like. And what is important here is a probe, because a probe has a coaxial laser, a coaxial camera, and as well as a coaxial light source. It is an intraocular procedure. So unlike the other two procedures, you have to enter the eye, you have to make a clear corneal entry, and you typically would deliver the laser like this. And this whitening of the ciliary process that you're seeing is the endpoint. So this is very good when you have a very sort of disorganized anterior chamber, because you can then treat only that portion of the ciliary process that you want. And if there's a lot of atrophy, you can even decide not to treat them. And this is sometimes useful when you're doing a procedure for the second or the third time. How does endoscopic cyclophotocoagulation do with refractory glaucoma? It also does pretty well. And if you look at this review on endoscopic CPC, you see fairly good intraocular pressure reductions in most of the papers. But don't forget that most of them continue to need one or two or more glaucoma medications. The Micropulse diode also uses a different console, even though the laser is similar. And this is what the probe looks like. The difference between the Micropulse and the conventional diode is that it subdivides the energy into short pulses with specific on and off times. So a device with a 31.3 duty cycle will have an on time of 0.5 milliseconds and an off time of 1.5 milliseconds per cycle. And this minimizes heat buildup, and that causes less damage to the adjacent non-treated tissue. So you basically treat this using sweeping movements. You sweep this probe adjacent to the limbus. And once you do that, you have to pass it for about 100 milliseconds. Each pass is about 10 milliseconds or so. If you look at success rates, and this is from a review that we did recently on the Micropulse, using similar criteria, that is about 20% IOP reduction, you see success rates that vary between 22 and 75%. So success rates are similar to that, what you see with the diode cyclophotocoagulation, but what is probably of greater benefit to us over here is that the risk of phthisis is much lower. But you do get some patients with good vision who complain of some amount of visual acuity drop, especially in the short term. I'll finish with the high intensity focus ultrasound, which uses a different principle. It tries to focus light on the thermal energy onto one point and prevent damage to surrounding tissues. And what happens with that is you get a very focused little band of small increases in temperature, which achieve the same result as the cyclophotocoagulation. The advantage here is because you have to do a UBM or an ASOCT for every patient, you can then choose what transducer size you want, and you can therefore target the ciliary processes more accurately. And it's fairly simple. This is what the device looks like. You have a cup like this, which you place on the eye, and then this is filled with the fluid. The transducer is placed here, and that's what the eye looks like at the end of it. In our own series of about 20 eyes or 24 eyes, we found eyes with a pretty high baseline IOP of 44 millimeters. The intraocular pressure actually dropped by close to 50%. These were all blind eyes, and we had fairly good results with those. In terms of side effects, nothing very major. We had transient hypotony in one patient, which recovered on its own, but otherwise there was nothing very major in this rather small series. So in summary, refractory glaucoma is difficult to manage. In sighted eyes or one-eyed individuals, every effort should be used to use conventional surgical techniques before you go to cyclorestrictive procedures. And all cyclorestrictive procedures should be used with caution, both because of the risk of phthisis and of sympathetic ophthalmia. Thank you.